this new webinar series of KSOS Scientific Committee, which we have titled as Expert Talk Series, where we will be focusing on bringing the experts in the various fields to present various selected niche topics, which will be specialty oriented and at the same time useful even for postgraduate students as well as for the comprehensive ophthalmologist. We are privileged to have Professor Pradeep Venkatesh from RP Center, All India Institute of Medical Sciences, New Delhi, as our expert speaker today. He was my teacher during my PG days. More than a teacher, he was a good friend and just like an elder brother, guiding us through the subject very patiently during those days. Though I landed up in anterior segment, whatever I remember in the posterior segment is from his teachings. I thank him so much for that. Sir is actually a little, sir used to shy away from these webinars. So I thank Dr. Mini for pulling him into this webinar series. Thank you, Dr. Mini. I warmly welcome you, sir, you being our first presenter in the expert series. It's my privilege also to welcome Dr. Anuradha Madam, who is a very renowned figure in the field of uveitis, who is working in Kerala nowadays. I welcome you to this webinar to join us, an expert panelist, Madam. I'm also pleased to welcome our KSOS members who are other panelists, Professor Jisha Madam from GMC Kottayam and Professor Sandhya from GMC Kozhikode to this webinar, who will be bringing up the discussions to this topic. I welcome our residents, Dr. Ashwati from Kottayam, Senior Resident from Kottayam, Dr. Ashi from RP Center, and Dr. Naufal from RIO Trivandrum, who will be presenting interesting cases during this webinar. My special thanks to Dr. Mini, who actually took the lead in organizing this first webinar among my team of other scientific members. Thank you, Dr. Mini. I invite you to be the moderator for this session. I welcome you all. Before we start the program directly, I request our president, Dr. Rajiv Sugmaran, sir, to give a message. He's actually, right now, he's in another meeting, so he has sent us a recorded message, which I request Mr. Ankit to play for the viewers.
Thank you, Dr. Sujit. As always, Dr. Sujit and his committee members have come forward with excellent innovative ideas. Following the successful launch of Masterclass series, we are now launching the Expert Talk, which is yet another commendable academic initiative. The inaugural Expert Talk by Dr. Pradeep Venkatesh will be a wonderful beginning to this series. Thank you, sir, for graciously accepting our invitation. We are also privileged to have an outstanding panel of experts, Dr. Anuradha ma'am, Dr. Jisha, Dr. Sandhya, to enrich the discussion and add depth to the session. Today's topic, the infectious versus immune-mediated uveitis, will be immensely beneficial for both practicing ophthalmologists and postgraduate students. What makes this online session truly special is the allocation of KMC credit hours. For the first time in the history of KSOS, we have been granted credit hours for an online academic program. My sincere thanks to the scientific committee, especially Dr. Mini Matthew, for making this possible. I wish the entire series a great success. Thank you.
Thank you very much, sir. Thank you, Mallika Madam, who's our Honorary General Secretary, and all the executive members for helping us in bringing out the scientific committee programs. As President already said, we are happy that we have been allotted 1 hour credit for this program. I request you all to continue throughout the program. We have to submit the screenshots of the program at various time slots. So be active in the discussion as well. Let me now hand over this session to our moderator, Dr. Mini. Thank you very much.
Thank you, sir. A very good evening to one and all. It is truly a very big honor to me to introduce today's speaker, Pradeep Venkatesh, sir, from RP Center. Sir is presently professor, and a short biodata of what he has been on. He has been working in the field of uveitis and retina for nearly 3 decades. And he has a deep academic interest in mainly the pathogenesis, evidence based management, retinal imaging, and research. He has been a principal investigator in more than 25 multicentric international trials. He has 300 PubMed index publication, an H index of 37. He is the author of 4 major textbooks, including the Oxford Handbook of Vitreoretinal Surgery. He has played a key role in the guidelines development of ICMR, NTB, National TB Elimination Program, diabetic retinopathy initiatives, and he has been at the forefront of integrating AI into retinal care. He is a passionate teacher and mentor. He is deeply involved in postgraduate training, interdepartment collaborations, and he has been the chairman for the development of the course curriculum for the National Board of Exam Fellowship in Vitreoretinal Surgery and the implementation of their weekly classes. Personally, Sir has been my mentor and guide at RP Center last year. He guided me through the basics and complexities of VR surgery. As Sujit sir has said, he usually shuns the limelight, but he has graciously accepted our invitation to share his vast experience with us. We are indeed privileged to learn from you, sir. Coming to uveitis, when a uveitis case does not fit into a textbook, we usually turn to experience. And today, I'm sure we are going to learn from one of the most experienced voices in this field. I also encourage the participant to post questions in the chat. With this, I welcome Pradeep Venkatesh sir for his talk. Thank you.
Thank you, Mimi. Thank you. Yeah, Mimi, is my slide sharing okay now?
Yeah, your slides are visible, sir.
Yeah, okay, yeah. Yeah, thank you so much then. And to Sujit, Mini, and all the society members, and also all the specialists who are there today, and also the youngsters. So, I mean, I think Mini was there with us for 3 months, and she's probably been troubled so much in Delhi by all of us here. So I couldn't refuse the invitation just to make up for all the troubles that she had to face at the RT Center. So thank you, Mini, again for having me here this evening.
Yes, sir.
Yeah, so this is going to be a very basic and simple presentation, but I'm still hoping that it will help the youngsters. Okay, so like the topic clearly says, it's going to be essentially case-based. I'm not going to discuss any theory at all over here. So I'm still going to be hoping that you gain something out of the next some minutes. Okay. So the topic for today is essentially infectious versus immune uveitis, and it's not infectious and immune uveitis. I'm making this distinction very clear at the outset because I'm not going to be covering the infectious diseases and the immune diseases, but essentially how you're going to distinguish the two with a series of cases. So that would be the objective of my presentation today. So why am I sharing these cases? I mean, we all know that the best way of learning is to learn from mistakes. So I mean, I've seen mistakes. I've made mistakes. I've seen mistakes being made over the past maybe 25 odd years. So not many of them share their mistakes. Okay, they take the high ground, but essentially we need to share those mistakes because we don't want other patients to suffer from those very mistakes. So the essential purpose of this whole presentation is to reduce the occurrence of those mistakes in the benefit of our patients. So I'm just going to cover this topic on 2 steps. The first step, so before you actually go into the question of whether it's infectious or immune uveitis, you need to address, is it really uveitis? And only then in the last couple of slides, I'll just cover the topic on infectious or immune etiology. So the first case itself, okay, I was a resident at this point in time. Just give me a minute, please. So I was a resident at this point in time, and she was admitted for evaluation. She was already started on anti-tubercular treatment, and she also had some pulmonary lesions, and that was the reason that she'd been started on anti-tubercular treatment. And one of the young consultants then had noted that there's not much of a response, so for that reason she had been admitted. So when she was admitted, she again underwent medicine review, and they said that except for the lung lesions, there's nothing abnormal. And in those days, I'm talking about maybe 96, 97, vitreoretinal surgery was not so advanced. Okay, so doing a vitreous biopsy or a lesion biopsy rather would have been very, very unsafe in those days. So a transcleval biopsy was done. So what do we see when the transcranial biopsy is done? What you're seeing over here is essentially an adenocarcinoma and not a tuberculoma. And you're seeing the post radiotherapy of the same lesion over here. So what actually happened in this particular patient? So we had a huge lesion. So we kind of as we become experts, sometimes we tend to take this call of looking at a lesion with the indirect ophthalmoscope, and then we are what should I say, impatient to make an instantaneous diagnosis, and we make a diagnosis, and then the test is showing something, and somebody is diagnosed it as tuberculosis, and then you treat the patient. But obviously, you know that this essentially was not uveitis. So the story here is that you need to do a complete examination, and this is also true for experts. So as we become experts, we tend to rely on our intuition, and sometimes that intuition can fail us. So we need to go and check whether there are cells, no cells. In the absence of cells means there is no uveitis. So this essentially was, yeah. So the other interesting thing in this patient was when we sent her for a repeat consultation, they found an abdominal mass and she had an ovarian carcinoma. Okay, so mistakes have happened at many levels in this patient. And because she already had a choroidal metastasis, maybe we couldn't have really prolonged her lifespan. Those days we didn't have targeted therapy, molecular diagnosis, and things like that. But essentially, from our side, it was a gross misdiagnosis. So the second patient again was being managed as an infective uveitis, essentially as toxoplasma retinochoroiditis. So this patient again was not responding to the standard antitoxo treatment. So I'm sorry about the image. So these are days when we didn't have digital imaging systems. Okay, this is an analog image that is being digitized, and the bitmap zoomed out the bitmap image. So you're seeing a lot of pixelation, but essentially you're seeing a lesion over here very close to the fovea. So the patient had 612 parts vision. So sir told me that he's not responding. Just have a look. And so I was seeing this patient again as a resident again. So again, there were no cells, but I still didn't know what I was dealing with. So out of curiosity, I just said, let me do an ultrasound evaluation in this patient. And the ultrasound showed up something I'd never seen. It seemed like there were two optic nerve heads that were there. And obviously, I mean, those days, I'm talking about the pre-internet days. The youngsters now may feel that, oh, why was it so difficult to make a diagnosis? So essentially, those were pre-internet days. We had to go back to the library, and then you go back to the National Medical Library, and you look up the atlas over there. So this is a typical appearance of a double optic nerve sign in choroidal osteoma. So this was reported as the first case from our country actually, and those days less than 50 cases have been reported when we first picked up this case. Again, this is not an infective toxoplasma retinochoroiditis, it's essentially a choroidal osteoma. So this was a young child, again with a history of fever, presented to our emergency, and was diagnosed as metastatic endophthalmitis essentially because of the history of fever. But because nothing was visible and ultrasound had been done, the ultrasound did not show any intraocular mass lesion. So the patient, however, what we heard, the patient was sent to our unit subsequently for a second opinion. So we were told that the child did respond initially to the treatment of intravenous antibiotics, and the lesion had again recurred. So one of our senior consultants, he asked again if ultrasound had been done, and we said there was no mass lesion. So his only question was, have you seen the fellow eye? And fellow eye showed a classic retinoblastoma. So again, what happened in this situation? So one thing as for youngsters is a uveitic eye is never going to have a dilated pupil. So all the hypopyon you're seeing and the iris deposits, they're metastatic deposits and they're not uveitic deposits. So a dilated pupil and uveitis do not go hand in hand. So you have to be very cautious. The other lead over here is a very young patient. So why did the ultrasound not pick up any lesion in this patient? Essentially because the child ultimately turned out to have a diffuse infiltrative retinoblastoma, which is again one of the rarest forms of retinoblastoma. Obviously, an MRI in this situation may have helped, but the fact is that the fellow eye was not evaluated. The diagnosis, we got carried away because of the vague history of fever that this child had. So this again is not an infective. I'm using the word infective uveitis and including endophthalmitis essentially to add to the problem of a masquerade in most of these cases. So again, a young child, the parents said the child did not have any problem. You can see a hypopyon over there. The pupil here is constricted. So initially was diagnosed as a hypopyon uveitis in a young child treated with topical steroids and topical cycloplegics. Initially seemed to show some response in terms of symptoms and in some decrease in the hypopyon, but the child came back again. So a more detailed evaluation then subsequently said the child was just 4 years old. So the father then said that the child had actually been treated for lymphoblastic leukemia. So now you know the diagnosis over here. So the history, the child was in remission. For the parent, it was like the child is normal. So it's happened to me in situations in adults where classically I'm seeing changes of malignant hypertension, but when I ask the patient, the blood pressure is normal, he says, my blood pressure is normal. For him, it is the current situation and not the events in the past. So sometimes you have to reelicit the history as to whether in the past they've had a situation. So we had to do, of course, the medical consultation or pediatric consultation did not reveal any blast cells in the blood itself, but so we had to do a tap, and the tap shows up lymphoblastic cells of ALL. So the fifth example, this was actually, I was a pool officer at this point in time, and this was referred by my senior resident to my professor or our professor, I would say, as a patient with the multifocal choroiditis and query APMPP. So when I saw this lady, the typical leopard spot, or like I said, those days it was just purely books that we had to learn. So the typical leopard spots are described in patients with intraocular lymphoma. So I had a very strong suspicion of intraocular lymphoma, discussed it with my professor, and we got an MRI done. The MRI was normal in this situation, but for us, the diagnosis of lymphoma again was not routinely being done in those times. So the patient was from a well-to-do family, so we lost her to follow-up. I've also done the ultrasound, and you're seeing a subretinal lesion over here. Obviously, this is not choroiditis, or this is not APMPP. There's an elevated mass that you can see over here. So many months later, this lady came covering her head, and then it had so happened that many months later, a repeat MRI had been done, and the MRI showed up CNS lesions typical of intraocular of a CNS lymphoma. And obviously, you treat at that point in time. So this was one of the first cases of intraocular lymphoma that I had seen, and this was not reported essentially because we didn't have a tissue diagnosis. We had not done a biopsy in this particular patient. But again, these yellow patches like this should not make us diagnose as a choroiditis or any form of uveitis. This is again a masquerade syndrome. So this was again during my residency days. This is not the images of the patient itself. This is of representative images of a similar patient. Okay, this was a 9-year-old child, and she had been diagnosed with viral retinitis, frankly, and she had already been put on antivirals, and she was not responding. And believe me, it was happening not at the resident level. It was also young faculty, young because we didn't have access at those point in time. So it was diagnosed as viral retinitis and admitted for evaluation because of no resolution or lack of response. You see that the media is pretty clear over here. So, and obviously, again, there were no cells in this patient, this child. So the young faculty said, let's take opinion from one of the senior consultants, and Sudeep will know who I'm speaking about. So the senior consultant did something very amazing. He just took his direct ophthalmoscope, and saw the child in the clinic, and he said, get the blood pressure measure. Now the blood pressure obviously was in the malignant range. So this was a malignant hypertension. Okay, so the story does not end there. So the diagnosis of viral retinitis was essentially also because the father gave a history of recurrent fever, some weight loss. So when we investigated the cause for malignant hypertension, the child turned out to have pheochromocytoma, and both pyrexia and weight loss is known to occur in patients with pheochromocytoma. She was operated in our surgery department here itself. So again, this is not so you always constantly, when you make a diagnosis of uveitis, somewhere you must document the presence of cells in the anterior chamber, cells in the retrolental space, and sometimes very trickily in the posterior vitreous itself. So this again was a patient vasculitis terminology. Again, there's only one patient where I'm using the word vasculitis in uveitis. Nobody knows where to place vasculitis. So this was a patient who was being followed up in our clinic for many years actually with the diagnosis of epiretinal membrane. He was just in his 20s. So when I saw this patient, I could not see any features of vasculitis. The rest of the retina seemed all right, except for an incidental hole that was there in the retinal periphery. And so I was curious to know what this exactly was. This again is the pre-internet days, the book only days. Okay, so we did the fluorescein angiography. Again, the image is an analog image that is being digitized, so the sharpness is not there. So I did not know what again this condition was. So, but I read up what is the differential diagnosis of an macular membrane, and that was the first time I actually came up with this condition called combined hematoma of the retina and retinal pigment epithelium, or the typical CHRRP. Of course, now we know those key features and we know many aspects of this disease now. But this again was the first reported case of a combined hematoma of the retina and retinal pigment epithelium from our country actually. Okay, so again, whenever you see these conditions, so even if somebody has made a diagnosis, be curious. I mean, what is the cause? If it's it cannot be a primary idiopathic membrane. If it's a secondary membrane, what is the cause for this membrane? So maintain that curiosity. Look for answers. That's very important. Okay. So this, I think now we're all aware of the moment I put up this slide, I think all of you will know what the diagnosis is, but essentially the story was the same. Many years ago, the patient was diagnosed as multifocal choroiditis, started on steroids, begins to worsen, then the patient comes to you for a second opinion, and then obviously it's a multifocal CSR as shown in these fluorescein angiographic images. So again, the same story here. We've not looked for cells, we've not documented cells, we've been inpatient, taking a diagnosis purely based on our indirect ophthalmoscopic signs. So one of the problems in ophthalmology is that all our diagnosis is based on visual cues. There is no palpation, there's no auscultation, there is no percussion. So your visual cues or the pattern recognition has to be impeccable if you're going to rely so much on your inspection features alone. So sometimes those inspection features alone are not adequate. So you need to do a split amp examination. You need to document the presence of cells. So now I'll tell you a reverse story that happened. I don't have this doctor's image. So this was, I just walked into my office. I was an assistant professor at that point in time. So he came with a printout of a time domain OCT. It was days of time domain way back in 2005, I think, 2004, 2005. So he came up with a printout with a neurosensory detachment, and he said, can you please see me? I said, and he told me he'd already been seen at one of the best centers in the country. And so I refused. I said, no, they've all seen you. There's no need for me to see you. So I just reassured him that we had a diagnosis of central serous retinopathy. So I just reassured him, and I had not seen him for a very long time. So what happened almost a year later, the very place that he had been diagnosed initially with CSR, he was there doing his DM cardiology, and I happened to meet him at dinner. So I just incidentally asked him how he was and what had happened to his vision. And then he told me that his symptoms had become bilateral, and then it was a diagnosis of Harada's disease, and he actually had to be put on steroids. So in the initial case 7, I told you about case 8A, I think, yeah, case 8A, I told you about how CSR was made into choroiditis, but in this situation, an early presentation of Harada's was made into a CSR. Again, in this situation, in the early stages of Harada's, you could probably have only cells in the posterior vitreous, and the visual loss may not be so dramatic with just the fovea is detached, but it was not an easy diagnosis possibly. But again, the emphasis here is that when you just have a neurosensory detachment, please do not make a diagnosis of CSR until you've clearly documented that you've seen the patient on the slit lamp, anterior chamber and retinal interspace, and clearly written no evident cells. Okay, this is a dictum that you have to follow to avoid this kind of a situation. So this was a particularly disturbing case for me. Okay, so you're seeing it to 2012, and it was diagnosed as a patient with viral retinitis. And again, the patient was on antiviral therapy when he presented to me, and it was disturbing because the consultant, the young consultant in the city, was one of our own residents, and they trained with us. So the diagnosis was very glaring when I saw the patient. So for that reason, I didn't know why it happened. But you're seeing a central patch of atrophy that is there, and the margins look aggressive, margins look pretty active over there. But the disc is relatively unaffected. So most inflammatory conditions would not spare the blood vessels, would not spare the optic nerve head. It's so close to the optic nerve head, and the absence of optic nerve head blurring, the blood vessels are pretty good. They're not congested. Hardly there's one hemorrhage that you can see in the left eye, probably because of a secondary CNV. But other than that, you don't see those features of inflammation at all. So this is obviously a case of bilateral and almost symmetric looking choroidal osteoma again. Okay, so there was no need to do any particular test, but a fluorescein was done. There was a tract inferior tract that was there. So again, a diagnosis of choroidal osteoma now is pretty frequently made. Everybody, nobody, I think, makes a mistake with choroidal osteoma, but this was maybe 10, 12, 13 years ago. So this patient again was referred as a mixed uveitis. I'm using the word mixed uveitis as a term that I don't know what else to call it, because in one eye you see features suggestive of choroiditis, and in the other eye the features, the membranous features that are there. So this is of the same patient. So it's not frequent to see a different anatomical diagnosis in the same patient. One eye showing anterior uveitis, other eye showing posterior uveitis. But that it does happen, but the frequency is very low. So in that situation where the anatomical diagnosis of uveitis is different in the two eyes, I tend to use the word mixed uveitis. So the right eye here is showing some features of probable choroiditis. You're seeing some involvement of the blood vessels over here, multifocal regions, but this side is completely obscured. So again, this patient, when he was referred, there was no cells in the anterior chamber. She was an elderly lady with no systemic features whatsoever. But the absence of cells again makes you want to look at the possibility of a masquerade syndrome. So the MRI of this patient actually said there were some lesions, but the radiologist diagnosed it only as chronic ischemic changes. So this is something, again, I want the audience to be aware that the CNS lymphoma is also very rare. So the neuroradiologists are not very aware of how the features look on an MRI. So many a times they diagnose it as chronic ischemic changes. And probably I have a couple of patients where biopsy subsequently showed it to be intraocular lymphoma, and then the brain lesions were re-diagnosed as CNS lesions of lymphoma itself. Okay, so whenever you have lesions, clinical lesions, suspect of a intraocular lymphoma, and somebody is reporting as chronic ischemic changes in the brain, it is still possible that is actually a CNS lymphoma. So you need to get a repeat consultation. So we did a vitreous biopsy in this patient, and you're seeing the B cells, large B cells in the vitreous sample over here. Again, a case of masquerade and not a case of uveitis or mixed uveitis. So why is it So, okay, so if you see, there's this edema over here, you can't see that, but what you're seeing as yellow lesion, the essentially subretinal infiltration. It's not like a granuloma over there, but this is essentially subretinal infiltration. And you're also seeing perivascular infiltrates like this sometimes may get misdiagnosed as chirales plaques, typically seen in toxoplasma patients. Okay, but again, you and patient again, one giveaway was the patient was elderly. So this patient presented to us in this form. He had a complete exudative, total exudative detachment in the left eye, and you're seeing evolving exudative detachment in the right eye. The patient had all of these images with him when he came to us. This is the last image you're seeing over here is what we took at our center. So you're seeing that over a period of 2 months, the patient has been treated initially with steroids, obviously as a diagnosis of choroiditis, and then subsequently ATP was started. At this point in time, apparently X-ray of the chest or a CT of the chest was done. Again, it showed up lesions in the chest and it was read as tuberculosis, and the patient was started on ATP. And this was, I think, the first week of December when the patient came to us. Obviously, the lesion has evolved over here. So the same thing with the right eye. It starts off as some pigmentary change over here, but then evolves quickly into developing an exudative detachment. So what happened over here? So again, the basic test of looking for cells was not done. Inpatient diagnosis of choroiditis was made purely based on the appearance of the lesion. And an ancillary test, it would have been very, very useful to an ancillary test, and ultrasound in this situation again is showing up a mass lesion over here. So what about the chest now? So the chest, what was being diagnosed as pulmonary tuberculosis, obviously turned out to be the primary site of the malignancy. The bronchoalveolar lavage revealed the malignant cells. So again, over a period of 2 months, this patient was diagnosed as uveitis, tubercular etiology, something that could have been completely avoided by just following some basic tenets of examination. So this possibly is the last case that I'll be showing over here. So this patient has a history of both immune uveitis as well as infected uveitis. So this patient had undergone multiple consultations, and he was from a very well-to-do family. When he came, there were 2 or 3 people accompanying him. So he came with this kind of a fundus picture, but the vision was only 660 and 636. Obviously, in an intermediate uveitis, there was no macular edema, so there was no cataract. So we couldn't, you really cannot explain. The first thing that raises a doubt of intermediate uveitis is that why is there's a difference in the visual acuity and the media clarity. So that alone raises questions. So when you do a fluorescein, what you're seeing is a placoid chorioretinopathy in this patient in both eyes. So it presents like this, and obviously when I say placoid chorioretinopathy, you immediately get the diagnosis. But what was most concerning over here was, this is again a representative image. So the only thing I like I say is a very rich family, so taking images like this would not have been possible for me. But the only thing I said was, can you show me the palm? So we presented it, and those palmar lesions were so striking. So then I asked him, did you show this to your doctor? He said, no, I had shown it to my doctor. They said it's a fungal infection, and trust me, one of the best big hospitals in Delhi had actually diagnosed this as fungal infection and had prescribed some antifungals to him. Okay, so there is an issue when a glaring lesion like this gets misdiagnosed, and now, like I said, the story you know. So whenever you're thinking of infective uveitis, particularly, you need to evaluate for some classic features. Okay, and the reason I'm saying that is some of these infective uveitis can be purely cured. So unlike typical immune-related uveitis, which you cannot cure, infective uveitis can be completely cured. Okay, so this really happened maybe 8 years, 10 years ago. But this kind of mistake. So whenever somebody, even if it's a person from the medicine department, I told you about the ovarian carcinoma, was that the abdominal mass was missed. There's a lesion over here diagnosed as fungal dermatitis or fungal lesion. So when your suspicion is strong, please discuss again, please assess with somebody who you feel has greater expertise. Okay. So this is not a case. I'm just showing you this, and like I said, I'm not going to show you all the infectious and uveitic forms. I'm only showing you this one particular form of infective uveitis, essentially because I possibly have seen 2 or 3 of these cases alone, and it's highly unlikely that any of you would actually see it or have seen these kind of lesions. So what you're seeing over here, this patient was admitted in the ICU. So the images were taken actually with the indirect lens itself. Okay, so you're seeing these lesions, multifocal lesions over here. But these again, and the solitary hemorrhage, it is very typical of cryptococcal choroiditis. Okay, so you suggest that do CSF analysis, and you're seeing the typical organism. Okay, the brain MRI also showed up some lesions. So patient was HIV, CD4 count was 71. So this is cryptococcal choroiditis. So sometimes the lesions can be very subtle. So you need to not miss these lesions, and sometimes just your diagnosis suspicion may help the clinician make a systemic diagnosis, correct systemic diagnosis. Okay, so this is a case of infectious uveitis. So the last few summary slides, so I've just listed out some of the infective conditions, immune conditions, and all of you know these conditions. I'm just not going to read out the entire list over here. So the emphasis again in how do you distinguish the two. So I've just again made a table over here. So most infective uveitis patients will have some predisposing disease. Okay, so you must not miss that disease because it also leads to some other systemic problems for the patient if you delay the diagnosis. Like I mentioned about the patient with syphilis, he also had HIV. Incidentally, that patient who had syphilis also turned out to be HIV positive. And one other thing I didn't emphasize in that particular case that I mentioned was when you come from a very rich elite family, it becomes difficult or delicate to actually elicit for these kind of diseases also. To elicit a history also becomes a little difficult. But I think you need to take the patient aside, or for whatever reason you need to elicit the history whenever the suspicion is very strong. So some of the other features are very clearly there, but most, and the other thing that is when the visual acuity and the findings are not corresponding, they're not correlating. The visual acuity is much worse than what the clinical evaluation is suggesting. Please think of an infective etiology. That's one of the features that I strongly use to think of an infective etiology. So worsening on steroids is not something that should happen. The initial that should not be used as a test for diagnosis. But I'm just mentioning what happens in a patient with infective uveitis. So the issues of toxoplasma and all the other conditions, I think all of you have actually seen. So I don't really want to go and talk about those conditions. So essentially use some of these points that I mentioned in this slide to differentiate between infective and immune uveitis. So this is the last of one final story before I conclude. So this happened just a couple of years ago. Okay, and she is a doctor with bilateral uveitis, known to one of our own specialists. The husband is again a specialist in the Department of Medicine in another hospital. So I've been seeing her for many years. So I got a call saying that she's complaining of pain, and I was not in the center late in the evening at the airport that day. So, but then I said, okay, is the anterior chamber depth all right? I told the depth is all right, but she had pain. Then, but anyway, we started her on the inflammation was not very severe. She was started on steroids and the cyclophylletics. Again, it was tapered. Then again, a month or so later, she again came back with the symptoms, same symptoms. Again, it was in the evening. So at that point in time, there was a thing that she's having a relative pupillary block. There is no typical iris Bombay, but I asked her only a few questions that does she read while she's lying down? And she said, yeah, typically that's when she was getting those attacks. And we all know we used to conduct this prone provocative test. Now I'm just mentioning this. Please don't take it as evidence. This was what led me to the decision ultimately. So I thought there was a relative pupillary block that was happening. So we decided that we'll just do YAG PI in both her eyes. So, but when we spoke to the glaucoma specialist was actually not very wanting to do the YAG PI, insisting that it is probably still related to the inflammation. And then I didn't see her for a couple of weeks. And they came back after a couple of weeks. And then I said that we have to do the YAG PI. And so then they told me that they had approached or they had met or discussed it rather. I'm not sure if they really met. They discussed it one other senior expert in another very good hospital, and they've been told to start her on antiviral therapy for CMV related uveitis. So now I'm bringing this kind of the story here is because this is an anterior uveitis. The vision was 6 in both the eyes. This is not of her eye. She was pseudophakic in both eyes. Despite that, there was a problem of relative pupillary block. Its sciatica was still there. Obviously, it's a chronic uveitis that I'm talking about. So, but she'd been told to take antiviral for CMV retinitis. And what the husband told me was that I was concerned because the dose that they were mentioning was much higher than what I actually give my own patients who have confirmed CMV disease. So that is the reason they did not want to start that. I just listened to the story that they said. I did not take that into, I completely ignored that kind of a suggestion because sometimes as youngsters you see a lot of things showing up in literature, and that pressure of literature or wanting to be a part of that story makes us want to do certain things which, if you critically analyze, may really not have a strong level of evidence. So unless you really find that strong level of evidence, please do not take these calls that this people are saying that this kind of uveitis raised IUP is related to CMV, and so just give them antiviral and things will settle down. So a lot of things need to fall in place. Okay, and all the level of evidence that you have for these kind of reports is not high. So please don't fall into that. That if you see the patient with this kind of an anterior uveitis and high IUP as an infection-related uveitis. Okay, so this is not to be done. And so with that, I think I'll conclude my talk. Thank you all so much for the patient hearing. Thank you.
Thank you very much, sir. It was really a great eye opener. All your cases were real pointers. So I think we should be extremely careful in making our diagnosis. I would invite the panelists, Dr. Anuradha Madam, former HOD Aravind Coimbatore. She is also an alumni of RP Center. Madam, we would like your comments and suggestions on what sir has discussed.
I didn't know that. Very good evening.
Yeah, actually, Anuradha Madam is an alumni of RP Center. She did her MD of TEL at RP Center.
Oh, okay, ma'am. Then you know,
Yeah,
yeah, you know lot of teachers here.
yeah.
Yeah.
Thank you. Thank you, and good evening. Dr. Pradeep, you may have forgotten me, but I have not forgotten you. You were a young consultant when I was doing my MD. And like, the rest of the ex RPC, I said, you were always very approachable. And I remember you telling me, it's not enough that you bring me problems. I would like to know the follow up as well. So, yeah. It's nice to see you and listen to you after so many years. So you presented a wonderful collection of cases, which could mimic uveitis. And, as you go through these cases, can you hear me clearly? Because I'm talking on the phone, actually. I have got a bad connection here.
Yes, ma'am, we can hear you clearly.
You can hear me. So,
Can
some of
Pradeep,
us.
can Pradeep sir please switch on your video, please?
On now, I do not know if it's on TV, but I'm in the office still. I don't know if I have a strong network.
Okay, sir. Then it's fine. Okay. Okay, madam. Sorry to interrupt you. Sorry.
No, not at all. So it's extraordinary, how somebody else from somewhere would have made the same mistakes. Like, For example, the primary vitreoretinal lymphoma, the choroidal osteoma. These are all cases, which I've also have misdiagnosed in my early days. And Sir did discuss about, some of the main points for identifying, or separating an infectious from a non-infectious uveitis. I would like to add some points of my own as well. So any uveitis in extremes of age, very young and very old, you should look at with suspicion. And I would also say that, any inflammation which starts after a surgery, whether it be a local surgery in the eye, in a patient who has never had uveitis before, or in a patient who has been hospitalized or has had some kind of systemic surgery, you should be looking at with a lot of suspicion. I think he already mentioned about the retinitis. Most retinitis we see in clinical practice is infectious. The exception being Behçet's, which turns the table around in that, here you have a non-infectious entity which can mimic a wide variety of infections. So Behçet's can look like end of, it can look like toxo, sometimes even viral retinitis. So that's something to be kept in mind. You can have it the other way around as well. Of course, the lack of response to treatment. So it's very important that you be aware of the typical picture and the typical response to treatment, so that when to look for other causes. And when we try to diagnose uveitis, it's like putting together a puzzle, and if the puzzle is not fitting, don't try to force fit it. Don't try to, just because you need a diagnosis, don't force the pieces together. And whenever you have doubt, go in for an early with tap or biopsy. So those are the additional points which I wanted to mention.
Thank you, madam. You had talked about biopsy, aqueous tap or vitreous tap. Many of us will have the confusion, like when do we have to go, which is a red flag for us to think about a biopsy, because a patient might be having a 6/6 vision, but the retinitis or vitritis might be still persisting. So
Right.
when is a red flag that we have to think of an alternative diagnosis?
So basically, you would go for a tap if you see a atypical picture, or you're suspecting a malignancy, or in the case, so I also go in for an early tap in a immunocompromised patient and the media is very hazy. For example, if it's a HIV positive patient with very severe vitritis and all you can see, some yellow stuff at the back, those cases I would go in for a tap early, because I know that even the serology might not be very reliable in these cases. So yeah. In addition to that, of course, lack of response to treatment, worsening on treatment, these are the other indications.
Okay, thank you, madam. May I call upon Dr. Jisha, Professor at Medical College, Kottayam, for her comments and suggestions?
Thank you, Mini. Thank you, Pradeep sir. It was almost a complete list of the varied conditions which we usually go missing, and that would have been very, very helpful for our postgraduates also. And regarding uveitis, I think the most important part is having a thorough knowledge regarding the varying presentations of uveitis. And we know that one uveitis doesn't present the same way in all patients. It itself has got varied presentations. And multiple types of uveitis also can have almost similar presentations. So most of the time it is our duty to have to sit with the patient, start from the history and try to correlate and whatever findings we get and to come to a diagnosis. And like Pradeep sir and Anuradha madam said exactly, we should not try to fit into a proper diagnosis. We should always be curious to find out. If you don't think that it is not correlating, then you should keep thinking, go with investigations. And when you're working in a multi-specialty hospital, you'll be very, very cautious about the diseases that are endemic in our situation, in our area, so that also will help in making a proper diagnosis. And investigations are definitely helpful, but we have to know that investigations, like especially serological studies and many other microbiological investigations, may not be 100%, may not have 100% sensitivity and specificity. So above all, there are situations where you have to depend on your clinical judgment and proceed accordingly. That's what I want to say.
Thank you, madam. Actually, in many of our in immunological tests, we could get false positive tests also, especially in the cases of viral antibodies. So, like in CMV, it comes positive sometimes. Adenovirus, it comes positive. So, when can we be sure actually that we are dealing with a viral uveitis?
Viral uveitis, if it is anterior uveitis, we should know that, like previously it was discussed. We have to look for certain features like a blood tinged hypopion. Sometimes raise in intraocular pressure will be high, and if it is becoming chronic, you will see some sectoral atrophic patches. And all these are present, and the patient is getting recurrent episodes. Then you are justified in evaluating the patient with an anterior chamber tap and going in for a viral PCR. And regarding the posterior manifestations of uveitis, we have to have an idea regarding the varied presentations, and we should know if the patient is immunocompromised, and we have to try to fit into the clinical picture that we know.
I think Pradeep sir wanted to add something.
Yeah, the one thing is I think we should investigate needlessly. That's going to add to the diagnostic dilemma. And almost all of these have a specific morphology, very clearly diagnosed, very clearly described. And all of these are clinical diagnoses. So the getting a viral test done actually is a misuse of those tests and should be discouraged, strongly discouraged. So please avoid doing that. So whether it's CMV retinitis, whether it's ARN, whether it is PORN, so almost all of these conditions have very typical appearance. So I don't think we should rely on any or get these tests done in the first place.
Yes, sir. Now in this, there are lots of cases of post-viral retinitis. So most of the people get investigated in the viral panel also. That is why that question arose.
Yeah, so post-viral retinitis, again, it's a very non-specific diagnosis.
Yes, sir.
I mean, you still don't know what to treat them. That somebody treats them with doxy, somebody with corticosteroids, combination of this. So, and many times it's complicated by their systemic features also. Like typically during the COVID time, you saw that their hemodynamic thing was so unstable. So many of those features could be because of hemodynamic instability of the patient itself. So we have to be a little cautious on whether you're actually dealing with a direct infective etiology there related to whatever caused the fever. So I'm not very certain that even in those conditions your viral panel will uh, help you treat the condition precisely. I'm not very sure of that. Yeah.
Okay, so there is a question in the chat box. If a patient is diagnosed with CNS lymphoma in remission, presence with vitritis without retinal lesions, is it necessary to do a vitreous biopsy for ocular lymphoma? Because maybe it might be difficult to get viable cells.
No, so I presume, should I take the question?
Yes, sir.
Yeah, so I presume that to start off with, this patient did not have ocular features, and during the course of the disease, the ocular features showed up. If that is the question.
Yes, sir. The patient is in remission on treatment.
Yeah, so in this situation, the vitrectomy would be warranted in the situation, and all the precautions to get a positive biopsy yield should be taken on how you collect and how quickly you transport the material. All of those precautions need to be taken, but in the presence of a diagnosis of CNS lymphoma, what you're dealing with the high probability of it being an intraocular lymphoma. So I think despite that, you should go ahead with the biopsy.
Yes, sir. So just for the benefit of the entire audience, sir, could you describe the method in which you do the vitreous biopsy?
Yeah. So the first thing is that there has to be a clear indication, and then you explain the reason that the test is being done. You go through with the proper consent process and all the pre-operative preparation that you need to. It is like any major surgery, all the pre-operative preparation and the consent taking. So, I'm sorry. Yeah, so after that, you have the pupil dilated. Many of these patients, as I see, they're all phakic patients, so you need to be extra cautious. We just use a single port in this. So we detach the suction line and then we attach a syringe. So the important thing is when I don't use a fresh syringe in these cases because you cannot reuse the same cutter. I don't use a fresh cutter in these cases because it's not ethical to use the same cutter in your subsequent cases. So use a cutter that you're likely to dispose of immediately after you've done the biopsy. So having said that, so you need to ensure that the dead space, there is a lot of fluid from your previous exam in that short segment of the tubing. So that should be completely sucked out before you start the procedure, and that may have to be done multiple times. Even small amounts of fluid in the tubing can dilute your sample or wrongly make you feel that you've collected some sample while it's just that the saline or the irrigating fluid of the previous patient that is there in the tubing. Okay, so the dead space that is there completely has to be empty within the tubing. So once you've taken that precaution, you make a single port. Normally, I use a 25 gauge port these days, and you're doing it under direct microscope visualization. So you focus very precisely. You tell the assistant what needs to be done at what precise point it needs to be done. So the reason I'm emphasizing that is if uh, the witness is adhering to the cutter and your not cutting is not on, and if your assistant keeps sucking on it, it can lead to severe distraction. Okay, so the assistant applies suction only when the cutter is on. So that's important to that precaution needs to be taken. And although they say that the cut rate should not be very high and you may lyse the cells, I'm not very certain that it plays so much role in the current context. So I usually keep it around 5,000 the cutter. And yeah, so the cutter and the other important thing is obviously there is going to be hypotony over here. So a couple of years ago, I just started putting in some air. I just take the air infusion line from the machine itself, and as soon as the cutter comes out, I place the air line into that particular port so that the hypotony is countered and the risk of hemorrhage and all that is completely eliminated. And we do suture the port after that. Yeah, and obviously we send a sample almost immediately. We speak to the pathologist beforehand also that there will be a sample reaching you for evaluation. Yeah.
Thank you, sir. May I call on Dr. Sandhya from Medical College, Kozhikode? She's a professor over at Medical College, Kozhikode. Would you have any questions regarding what has been presented, or would you like to add something?
Am I audible?
Yes, you are.
Sir, actually, I have a doubt. See, we have a young male, actually. He presented with mild anterior uveitis, and he had early band keratopathy, both eyes. So that was anterior uveitis was well responding with the topical steroids. So when we fundus actually examination looked almost normal, but there was some peripheral pigmented changes. So we did an FFA which showed peripheral vascular leakage, and he had other systemic features of Behçet, and he was diagnosed as Behçet. And he was started on oral ulcers and genital ulcers was also there. He was started on steroids and then tapered to immunosuppressants. My doubt is actually, since he doesn't have much clinical features, how will we know the disease is under control? Should we do serial FFA for that patient? We have, so again, like 2 or 3 cases like that. Fundus doesn't show much active retinal vasculitis as such.
on treatment now, or he's not off treatment now? He's on or off
No,
treatment?
no, the patient is actually on treatment. He's on treatment for almost 6 months now.
Okay.
So they are actually tapering steroids. Now the bisalon is only 10 milligram. So how long should I have to continue the immunosuppressants? Should I do a FFA again, or what is the line of management?
So with Behçet's disease, irrespective of what treatment, this is the biological statement. Irrespective of what treatment is given, what kind of immunosuppression is given, almost 25% will go blind over a period of time because of the disease nature itself. So in this situation, I'm not sure if biologicals have been considered. Biologicals were needed to control the disease, or he didn't need biologicals.
Yeah, patient is on actually infliximab 8 weekly now.
Okay.
He was given 0 to 8 weekly. He's on 8 weekly infliximab now.
Yeah. So if it's already on
And
biologicals, yeah.
also on azathioprine.
Okay. So with management, you need to take all the precautions of monitoring and all that. With
Yeah.
infliximab, the problem with biologicals that concerns me is that moment you withdraw the biological, the disease comes back. So whatever, I mean, whether you have activity, no activity is not of concern. The moment you withdraw, some of them say almost 50% comes back, some of them 80%. So if you see the most recent adjust trial that's there in the Lancet, published by Dr. Ramanan and I think Dr. Nisha, okay, sorry, yeah, Dr. Nisha Acharya, I think from the US, I think they published this adjust trial. Okay, so they found that the relapse comes back because you can regain control by starting the biologicals again, but you cannot really remove the biologicals completely. And when we talk about biological in that situation, the risk of tuberculosis is real. So we have to be concerned about that. So I'm not going to depend on my treatment decision based on any ocular activity or no ocular activity.
Okay.
We'll have to go with what the specialist says in this. And nowadays in our center also, the biologicals are being more frequently, despite this concern. They do all the baseline tests for tuberculosis. But in your patient, I think I would not be the deciding factor for stopping the therapy because this is a systemic disease. We need to understand it's
Yeah. Okay.
a systemic disease. Yeah.
Okay.
Thank you so much for that discussion. May I call upon Dr. Ashwati from Medical College, Kottayam to present her case. Dr. Ashwati, you are available?
Yes, ma'am.
Okay. You can share your screen. I would encourage all the participants to put in their queries in the chat box. We would be happy to be able to answer any of them.
Ma'am, am I audible?
Yes, you are audible. You can start.
Okay. Good evening, everyone. So I'm presenting the case of a 14-year-old male child who presented with complaints of pain, redness, and photophobia in right eye for 1 day duration. So 2 weeks prior to his ocular symptoms, he had a history of fever, which was followed by painful swelling in his parotid area, which was associated with vomiting and loose stools. And he was treated elsewhere with antibiotics and analgesics. The patient was better and was not fully relieved with treatment. So on examination, the child was febrile, and there was bilateral parotid and submandibular salivary gland enlargement with mild tenderness. There was submandibular lymphadenopathy noted. All other systems were within normal limits. Coming to the ocular examination, his visual acuity was 6/36 in right eye, and right eye showed features of fibrinous anterior uveitis with fine KPs and 3+ cells. The fundus was hazily visualized but appeared normal. The IOP was also within normal limits. The left eye was normal. And we came to a diagnosis of acute non-granulomatous anterior uveitis right eye, which was probably secondary to viral infection. So he was treated with topical prednisolone eye drops, cycloplegics, and had symptomatic improvement. The patient was admitted under infectious disease unit with a diagnosis of viral parotitis, probably mumps. So he was investigated, and investigations, mumps and measles IgM came back to be negative. The blood cultures and urine cultures were negative. Viral markers, ANA was negative. But the total count was elevated with predominant neutrophils. Peripheral smear also showed similar picture. Inflammatory markers were also highly elevated, and USG confirmed the presence of bilateral parotitis and submandibular silodinitis. So the patient was started on IV antibiotics, analgesics, and other supportive medications, and was under ophthalmology follow-up. On the 5th day, he developed features of pancreatitis with significantly elevated serum amylase and lipase. The USG abdomen showed multiple enlarged mesenteric lymph nodes. He was conservatively managed and the abdominal pain relieved. So though he became comfortable after the initial treatment with respect to the eye, on 9th day, he became symptomatic in both the eyes with marked deterioration of vision in right eye. And also he had grittiness and floaters at that time. On examination, there was bilateral pan-uveitis with severe vitritis in right eye. The vision in right eye was only counting fingers close to face, and vision in left eye was 6/36. There was severe anterior segment inflammation in right eye with 1 millimeter hypopyon, multiple point posterior synechies. The fundus showed grade 4 vitritis. And in left eye, there was 2+ cells in anterior chamber, and fundus showed grade 1 vitritis, and the IOP was also very low in both eyes. So this was the picture of the child at that time of presentation. And there was swelling of both his lacrimal glands at that time, and the existing parotid and submandibular swelling also increased. Since he complained of grittiness, dry eyes, and dry mouth, we did a Schirmer test and revealed very low values in both the eyes. So we came to a final diagnosis of acute bilateral non-granulomatous pan-uveitis with dacryoadenitis, silodinitis, pancreatitis, and lymphadenitis. And the possibilities considered were post-viral, sarcoidosis, tuberculosis, and IgG4 disease. And a detailed workup was done, and his serum ACE, calcium, chest, CT chest, Manto, chest X-ray, RA factor, and ANCA were normal. Meanwhile, he was started on systemic and topical steroids. A rheumatology consultation was sought and considered the possibility of Sjogren's syndrome. However, the anti-SSA, SSB ELISA was negative. So since we were in a diagnostic dilemma, after consulting with the rheumatologist, we decided to take a wedge biopsy from the lip mucosa, which revealed features which was compatible with Sjogren's syndrome with a focus score of more than 1. And IgG4 immunohistochemistry was also negative. So a diagnosis of primary Sjogren's syndrome was made, and he was started on injection dexamethasone followed by oral steroids. TAB HCQ was also added on, along with topical steroids, cycloplegics, and lubricants. So 2 weeks after the treatment, his vision improved, the vitritis decreased, the parotid swellings disappeared, and vision in right eye was 6/12 and left eye was 6/9. So he's on follow-up for 8 months now, currently on TAB HCQ, methotrexate, and Visalon 10 milligram. He received 2 doses of rituximab injection. However, he was having recurrent episodes of mild anterior uveitis both eye with IOP hikes on topical anti-glaucoma medications, and is maintaining a vision of 6/9 in right eye and 6/6 in left eye. So my questions to the panelists are, would you agree with the possibility of Sjogren's disease, considering the rarity of acute severe uveitis in Sjogren's? And even with 3 immunosuppressive agents, the patient was having a recurrent inflammation in both eye with IOP heights. So would you consider the possibility of an infective cause, a viral cause? And is there a need for ACTAP and PCR?
Anuradha madam, would you like to take that query? Would you agree with the possibility of Sjogren's?
I have to admit that, I've never seen this kind of intraocular inflammation in a Sjogren's syndrome. So I have very limited, experience with this. Was this patient vaccinated for mumps?
Yes, ma'am, he was vaccinated.
For mumps. Yeah, I've seen mumps-related keratouveitis and retinitis, but this kind of feature, and I would also think that this kind of a very acute presentation, that too in a 14-year-old male child is very, 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 very unusual. I would like to hear Dr. Pradeep Venkatesh's opinion on this.
Pradeep, sir?
Yeah, so my first consideration would have been a Hayford syndrome or a Mikulicz syndrome secondary to sarcoidosis. I really would not have thought of viral etiology, and the Sjogren's may be secondary Sjogren's. So I may have missed it. Was the serum ACE level done in this child? Because we have that
Done.
result. It was done.
It was done, sir. It was normal.
Okay, and the point that when the levels were tested with the child on steroids at that time or off steroids, because the child has been on steroids, it's natural to become negative. So that is one consideration, that now if the child is on, if he's having recurrent symptoms and the child is not on steroids, maybe a good time to test for serum ACE again. So you have a biopsy diagnosis, so that I'm not sure if it was a secondary Sjogren's kind of a thing. But did you specifically look for granulomas of sarcoid in the biopsy in the situation? Because it's known, Hayford syndrome is known to have uveitis, and if it is not treated on time, it can quickly become aggressive. And steroids really work very well in sarcoidosis. So I'm not very sure if the child needs so much of immunosuppression. I would want to keep that as my primary diagnosis of the sarcoid-related uveitis. Although it's non-granulomatous, I think based on the granuloma alone, we should not be considering it to be non-sarcoid uveitis.
So, sir, will there be a need for an AC tag or a PCR?
No, see, one word of caution here is that in the vision is 6669. There's no role for doing any invasive tests. I would really discourage that. And it is there again. It is there in publications of 6869 vision steps have been done. But that is something that I would discourage. It's not normally a done kind of a thing or an encouraged kind of a thing. It's not an innocuous procedure. The biopsy is not an innocuous procedure. And PCR has no role. PCR has absolutely no role whatsoever in many of these diseases. So, yeah. So I don't think that would be necessary at all. So, so when you say that there is relapse, you have to see how frequently the relapse is and at what dose, whether it's now turning into a steroid-induced kind of secondary glaucoma, I'm not very sure. So that the endoscopy is done, it will become an angle closure related to inflammation, it's still an open angle. So whether there's a pupillary block, so all of those considerations should be there. And IOP alone should not make you want to keep your add or
Sir, I have a doubt.
yeah.
If it was an purely immune-mediated uveitis like Sjogren's syndrome or even a sarcoidosis, with this much of anti-immune therapy and even rituximab, and he's already on other Vislone, methotrexate, and I think mycophenolate. So with all these medications, if it was immune-mediated disease, we expect it to be under control. So, like in that scenario, can we consider it as viral etiology? Because when we searched literature, we thought that initially, with all the clinical pictures like the dacryoadenitis, parotitis, and even parotitis, the pancreatitis, everything is possible with mumps. And second is Epstein-Barr virus is another virus which can also present in a similar way. So if the viral part in antiretrovirus, is it going in a chronic phase because of systemic immunosuppression? And in spite of all these immunosuppressants, if it is purely an immune uveitis, why it is not getting under control?
Yeah, but what is the current relapse like? How frequently does the relapse have? And is it just anterior relapse or posterior relapse, or both anterior and posterior relapse?
No, it's only an anterior relapse.
Yeah, ma'am, see, only anterior relapse. I'm not going to treat anybody with so many systemic medications just for an anterior relapse. So I think I would be more, I would like to taper my steroids more gradually, switch to some other steroids, because exposing a child or even an adult to so much of systemic drugs, I think we also expose them to the side effects, the harm of these drugs, and there is no posterior risk. I would try to modify the topical treatment and try to get the control. Like I was saying in the last case, I said anterior uveitis alone, I think, does never warrants so much of therapy. It's usually initially it's not being treated aggressively. There are issues that are there, so I'm not very comfortable giving patients so much of medication if the relapse is only anterior. So I would like to withdraw them one by one.
But with the steroid because yes, we don't know whether it is a steroid responder or the IOP hike is associated with the tuberculitis. And we have difficulty in treating the patient's anterior segment inflammation with topical steroids because of the IOP hike also.
Yeah, so one is you need to ascertain whether it is steroid related or is it disease related. If it's disease related, if the angle is already closed, I think no amount of systemic medication is going to help the IOP. If the angle is open and then we feel that it is inflammation related, then maybe, but we also need to see what the gonioscopy is showing in this situation. And
Actually, it's not a constant rise. It goes we get spikes. In between, it goes to 30, and sometimes it is with single 1 or 2 anti-glaucoma medications. It is normal also in between.
no relative pupillary kind of a situation happening.
No, pupil is except one posterior synechiae, rest of the pupil is free.
So some other conditions like like sleep septicemic and so those conditions also, I mean, although they say it's CMV related and things like that, evidence is not there. So some of these non-specific uveitis also are known to develop high IOP. It's difficult to manage and where you don't give systemic therapy. But I think maybe relooking at the exact precise cause of the IOP before attributing it to the inflammation alone, I think would be useful. Yeah, I certainly would like to reduce the amount of systemic treatment.
Okay, thank you.
Can I add something?
Yeah, sure,
Yeah.
madam.
So even if you think it is mumps, there's no specific treatment for it. But like even if you think it is mumps, it doesn't have any specific antiviral treatment. And literature says that mumps infection can trigger off immune-mediated Sjogren syndrome. So the question is the patient on topical steroids now? Have you completed?
Lotipretnol, right?
Right. Has a patient ever been put on Predfort rather than Lotipret?
Yes.
What happens? What happens when the patient is on Predfort? What happens to the uveitis and what happens to the IOP?
Actually, when he was on Predfort, his IOP went high, and then that time it was shifted to lotipretnol. While he was on lotipretnol, in between he had mild recurrence of inflammation, and that time the drug was changed to prednisolone with added and IOP showed up, and he was on added anti-glaucoma medications. So actually, we were not really able to correlate whether it is steroid responder or tuberculitis. That exact diagnosis we are not having. We are not able to really say that it is steroid response and not tuberculitis.
Right. And like Sir asked, how bad is the flare-up? Is it as bad as the original presentation, or is it milder? The anterior uveitis, how bad does it get?
No, it is never bad as the initial presentation. It is only a mild to moderate.
Right. Because I'm thinking, if this is actually an underlying infectious process, with this massive amount of immunosuppression, you should be getting a steady worsening. The child would have been in trouble by now. So it might be a good idea to wean him off the medication and see what happens. And if there is a recurrence, I would go for an AC tap.
Okay. What would be your option, ma'am, for this steroid responder? If he is a steroid responder, what anti-inflammatory medication will you use?
See, with uveitis, it's important to control the inflammation. Not controlling the inflammation, will lead to secondary glaucoma in other ways. So, if you have to use AGM, or if you need surgery, you have to go with that. But withholding, appropriate anti-inflammatory therapy and using a suboptimal anti-inflammatory therapy, doesn't really help in the long run.
Okay.
Sometimes you have to bite the bullet.
No, as a child ever needed a systemic anti-trauma medication to control the intraocular pressure? It's controlled with topical medication alone.
Most of the time, it is controlled with topical medications only.
Yeah. So then I think we should take out the systemic therapy, and I think try to manage the inflammation and the IOP with topical medication alone. I think try to do that.
Okay.
Yeah.
Okay, sir. Thank you. Thank you, madam.
There is a query in the chat box. Will mesenteric lymph node biopsy be useful in diagnosis? Anuradha ma'am?
Does the patient still have
No.
mesenteric lymph nodes?
No, that was there only at the time of initial
In the
presentation.
beginning, yeah. You could also, I think already a salivary biopsy was done, right?
Yes.
So it wouldn't probably add to. Thank you so much
Yeah.
for that case and for the discussion. May I call upon the next presenter, Dr. Ashi from RP Center, for her case. Dr. Ashi, are you ready?
Yeah, I'm ready. One sec.
Okay. Could you share your screen?
Yes, I'm just one second trying to.
By the time she's getting ready, there is another query. The uveitis caused by checkpoint inhibitors, which are frequently used these days in metastatic cancer, can present diagnostic and treatment challenges that can complicate the patient care. So is there any specific clinical tip to identify such a problem? Pradeep sir?
Yeah, so we actually had a study that we undertook in patients with checkpoint inhibitors, and those were just on the conventional chemotherapeutic agents, and we didn't really see much of a difference in the two. In the uveitis, we see that out of 100 patients, there are two patients presenting with uveitis, but typically this is an anterior uveitis, and you don't have to completely withdraw medication. They respond well to steroids, and the systemic medication is you have to prioritize the systemic disease. So, and nobody recommends removing the systemic medication itself. And one of the patients was on imitinab. So for leukemia, and obviously there is no more stronger alternate treatment available. So reduce the dose, treated that young lady with just topical normal uveitis, and she settled down with that alone. Yeah, so you don't have to modify anything, even if they have uveitis. They're never so severe, I think. Yeah.
Thank you, sir. That's a good point. Dr. Ashi, you can start.
Ma'am, is my screen visible?
Yeah, it is visible.
Yeah, okay. Good evening, everyone. I am Dr. Ashi Gupta, Senior Resident RP Center, and today I'm going to be presenting a case on monoocular HSV-1 acute retinal necrosis, therapeutic escalation, antiviral switch, and buccal success. So my patient is a 30-year-old male who presented to us with sudden painless diminution of vision in the left eye. The visual acuity at presentation was 1/60, and the right eye was no PL. The systemic history was unremarkable. The immunostatus was he was an immunocompetent patient, and so there was a rapid vision loss in the only seeing eye. So it necessitates immediate diagnosis and aggressive therapeutic intervention. So at presentation, as I told, right eye was thusical. In the left eye, there were signs of active anterior uveitis, diffuse stellate KPs distributed across the endothelium, 2+ cells. The lens status was clear. So along with anterior segment inflammation, there was an accompanying posterior segment pathology. As you can see in the image, this is an Optos wide field which shows peripheral necrotic patches, peripheral confluent yellowish white patches with discrete borders. There is a marked arteriolar attenuation and perivascular sheathing. Then optic nerve head disc pallor can be centrally observed, suggestive of optic neuropathy. And the distribution is circumferential peripheral involvement with active leading edges moving towards the posterior pole. So by the clinical picture per se, our provisional diagnosis was acute retinal necrosis. We then planned to we gave an intravitreal. So before that, we did an anterior chamber tap and sent the sample for polymerase chain reaction testing. And we detected the HSV1 was detected. We did all the required baseline systemic monitoring, the renal function, and ruled out all the other viral markers like HIV. And these tests were done. And so our diagnosis came out to be ARN. So our initial treatment protocol, we decided to go on a dual mechanism antiviral therapy. That is, we gave intravitreal injection along with systemic antivirals. So we gave intravitreal ganciclovir 6 mg 0.1 ml repeated every 72 hours. And oral valacyclovir was given 2 grams TDS. And the safety and monitoring, all the renal functions, etc., were all monitored. Then even after giving valacyclovir for approximately 2 weeks, we did not find the response that we were expecting. There was minimal change in the regression of lesions. The borders were still active, and the vascular status, there was still persistent attenuation. So since it was the only functionally the patient was monoocular, so there was a need now to escalate. So we escalated to IV antivirals, and we started the patient on intravenous acyclovir, 13 mg per kg, 4 times a day for 7 days, along with mandatory IV hydration. And we did that for 7 days, and the lesions started to regress a bit, but the response was suboptimal. So then we shifted a therapeutic switch. We shifted to famciclovir, 500 mg TDS. Rapid resolution of active retinitis lesions were observed within the 7 days of switch. So we decided to discharge the patient, but before discharging, we did a prophylactic laser barrage posterior to the margin, posterior to the posterior margin of the necrotic patches. But still, despite our preventive strategy, our prophylactic laser barrage, 1 week post-discharge, the patient presented to us with retinal detachment. There were areas of thinning mostly at the supratemporal margin, the anterior margin of the junction of the necrotic and the normal retina. And it was not one single break. There were multiple areas of retinal thinning. So we decided that since the breaks, they seemed to be very anterior, no posterior break was noted. So we decided to go for a band buckle procedure. We marked all our suspected areas. All of them, they lied in the temporal anterior, close to the aura. We marked them. We did a very light cryopexy. Then we put a 180-degree temporal buckle to support the entire necrotic areas. And then a tightening of the encircling element was done. And then post-op, the retina was attached. Our lesions, they were healing, as we can see in both the images. The lesions are resolving in the late post-op period. The lesions have resolved. The entire area is well on buccal indent. And post that, so discussion is medical management. PCR confirmation is pivotal in cases of ARN. A timely therapeutic escalation in monocular patients, limited response to initial therapy mandates immediate escalation to IV or alternative antivirals. And famciclovir, it's effective alternative when acyclovir response is suboptimal. Surgical, there are, as we all know, ARN has very high risk of rhegmatogenous retinal detachments, and they occur at the junction of the necrotic and healthy retina. buccal versus vitrectomy, since in our case the lesions were peripheral, so we could plan for a buccal and prevent the complications of vitrectomy. And corticosteroid, we did start the patient on Visalon as well 48 hours after 48 hours after we started the valacyclovir. So the take-home message is, in acute management strategy, immediate combined therapy, PCR confirmation, early reassessment. We need to follow up the patient regularly to see if these patients are prone to develop RD, and we have to our main aim is to protect and salvage the eye. So the panel are, for RD in ARN, when would you do buccal alone versus PPV with encircling band plus silicone oil? Would a monoocular status change your choice? And also, after how many days of minimal response do you consider treatment failure and switch or augment therapy? What is your step-up algorithm?
Thank you so much, Ashi. That was a great case and you had managed it so well. Patient must be happy. May I ask Anuradha madam to answer that query?
Okay, I'm going to skip the first part because I'm not a VR surgeon, and I will leave it to the VR surgeons to answer that question. The second part of it, when would I consider changing therapy? So, my experience with ARN, it's that most of the cases, when they come to you, they are already in a fairly advanced stage. It's very rare that you're lucky to get an ARN, which is very limited. So I prefer to admit them and treat with IV acyclovir in almost all cases. It is very unusual for me to give oral Valsivir as the first line treatment. So the reason for that is you send them home on oral medication. You never really know what happens at home, and that first 1 week is very critical. And while under admission, I review them daily, and I can see what is happening with the eye. And it also allows me to give ganciclovir injections at least twice weekly. So my experience with ARN is that even when you start IV acyclovir, for the first usually 2 to 3 days, the lesions may continue to progress, but then it should just stop. So there might be an initial progression and then it stabilizes. And then it starts regressing. So the time period where I would start worrying is around 7 to 10 days. Literature says 10 days. That's when you should think about a primary treatment failure. So in those cases, I think you should consider switching to either Foscanet. I'm not sure how widely available Foscanet is, or you can consider famciclovir, like in this case. And I prefer to do a combination therapy with IV acyclovir and intravitreal ganciclovir in almost all my cases, unless it's, like I said, it's early ARN. Yeah.
Thank you, ma'am. Dr. Sandhya, would you like to add something?
Hello, am I audible?
Yes, you're audible.
Yes, as Anuradha madam said, we'd also like to prefer IV acyclovir. We also recently had a patient, but luckily, as madam said, it was early, but still we managed the patient with IV acyclovir, and luckily the patient was stable. So IV acyclovir is the first line of management.
At which point would you consider steroids when you're managing a case of ARN? Madam, Anuradha madam?
Yeah, so there is a very strong immune component in ARN, although it's an infection. And many of them have optic neuropathy. So I start steroids in all my cases maybe after 48 hours. Yeah. So like I said, admitting the patient and reviewing them daily in those early days allows you to reassess, on a daily basis. And if that window is gone, like it's a very unforgiving disease, actually.
Pradeep sir, would you like to add? Actually, Ashi's first query must have been answered practically already by Pradeep sir, but we would like to know his response.
Yeah, actually, few questions that I have. I didn't probably again register. What was the cause for phthisis in the fellow eye?
Ashi?
Sir, the patient gives a history that the eye had become thicycle during his early childhood. He does not give any history of any trauma. By the look of the right eye, it seemed that it might have been lost due to some uveitis sequelae. As we could see, there were some cratic KPs on the endothelium. There were 360-degree posterior synechia was there. Was a total white cataract. Apart from that, on ultrasound, the structure of the globe was distorted. So nothing else. There were no documents which could have told us that what happened in the right eye. Neither does the patient tell us any history of redness or something.
Yeah, thanks, actually. Yeah, so the other thing that I just mentioned that I'm not very fond of PCR, and Ashi said that it's pivotal in diagnosing and managing. Okay, so we both from the same institute. So I'm just trying to highlight I'm still the old timer, and we have a lot of young faculty who like to do these tests. But I mean, we do discuss many a time about whether to do or not do these tests. We don't prevent yeah, I mean, getting these tests done, but I'm still not very sure about the value addition when these tests are done. Okay, so that's one as far as the PCR goes, because yeah. So the treatment in this situation was the patient on steroids. So one thing as the thing we know that 70% of patients with acute retinal necrosis, irrespective of what treatment is given, would develop retinal detachment. Okay, so and there is a question on whether laser actually hastens the development of small holes. So initially it was being done regularly, but then there was a report that patients who were lasered actually had a higher incidence of retinal detachment than the withheld laser. So one is that like ma'am was mentioning, it is not a good disease to probably one of the worst uveitis conditions to have. So in this current situation also, I'm not very sure if I'm very certain that the treatment changed the natural course of the disease. In this situation, normally we say that in ARN, you treat essentially to prevent the disease from becoming bilateral. The involved eye will continue to progress, and the efficacy of treatment is there, but whether it prevents the subsequent retinal detachment, that is not certain at all. So in that context, I'm not very sure the dose escalation or changing to a different transit fluid. I'm not aware of the cost considerations of these newer antivirals also. So that is one aspect. I'm not really uh, sure if all of this changed the natural history. Now coming to the detachment itself. So I'm not again. How long was patient still on steroids when the detachment developed? She or steroids?
So the patient was still on steroids.
What dose?
Sir, Visolon 50 mg.
No, that must have been pretty long because uh, it started off at what dose?
It started off at 60, but we kept it at 50 because the vitritis, the component of vitritis was there, and the patient was since the patient was initially not responding, so we did not want to reduce the steroids to counter the inflammation. So that's why for a very long time the patient was on high dose of steroids.
Yeah, so the reason I'm asking this question, Ashi, is also that these patients are known to develop exudative retinal detachments. And in your intervention, it was an unconventional kind of an intervention because typically the breaks develop at the junction of the healthy and the necrotic retina. You don't expect only the anterior part of the retina to be having these breaks. And for the images that you showed us, the extent of the the posterior margin was spread into the posterior retina, beyond the equatorial retina. So I was just wondering if there was also an element of exudative detachment that was there, or the breaks were anteriorly. So if it was just anterior, I would have gone ahead with the same decision. But that's a very, very atypical happening that breaks and that the breaks are so anterior in patients with ERA. So the follow-up also, I think we need to have a careful follow-up. There's a high possibility that posterior breaks may develop, and we may still have to revert back and do vitreoretinal intervention.
Right, sir.
I have a question, sir. Do you combine intravitreal injection of Valg and cyclover in every case, or was it given because it is one-night patient here?
Yeah, Archie?
Yes, ma'am. Since the patient was one-eyed, so we wanted to be a bit more aggressive. That is why we did give intravitreal intravitreal ganciclovir with oral valaciclovir.
And the oral valaciclovir dose also was little higher, right? Usually we give 1 gram. Here it was 2 gram that was given, right?
Ma'am, 1 gram is for maintenance. Initially, loading 2 gram TDS can be given.
For ARN also.
Yes, ma'am. Valacyclovir. Valganciclovir is for that's CMV, but for ARN valacyclovir, gram TDS for loading can be given. For maintenance, we give 1 gram.
Okay.
Can I add something? So the 2 gram TID is considered to be equivalent to IV acyclovir 10 milligram per kilogram body weight. The 1 gram is actually considered to be equivalent to 5 milligram per kilogram body weight of IV acyclovir.
Okay.
And the other point I wanted to add is about the combination therapy. So for the last few years, we have been using a combination of IV acyclovir and intravitreal ganciclovir. Prior to that, our RD rates were like almost 90%. We used to have, RD in almost every case. But I feel after starting the combination therapy, I feel the RD rates have come down. This is observation.
Okay, ma'am. Thank you.
Initially, we used to worry whether, there's extensive necrosis and whether giving injections would actually increase the risk of RD. But it's the other way around.
Ma'am, how many injections you give intravitreal?
So I usually use 2 milligrams. The max I've gone up to is 5 mg. And it's given, like every 3 days. In that initial phase, you can repeat it until you see a definite regression in the retinitis.
So one additional factor is that because the risk of retinal detachment is so high, some surgeons are actually suggesting an early vitrectomy in these cases. Obviously, something in a one-eyed patient you would want to hold back. But in this situation, right from the beginning, the prognosis was not good, essentially because the optic nerve involvement, the central retinal arteriolar involvement was quite very, very significant. So I don't think it was a good prognosis right from the very presentation.
And one more thing, is syphilitic ARN common? Have you come across any case of syphilitic ARN, sir?
Syphilitic ARN normally we more like a chorioretinitis. So ARN per se, I think I have not made a diagnosis of syphilitic ARN. Yeah.
Actually, the term ARN is reserved only for HSV and VZV, not even the other organisms, according to the Sun too. Yeah.
So I would like to thank Ashi for sharing this case. Actually, she has come back after a very hectic OT, but I thank her for accepting the challenge to present her case to us. Now we have Dr. Mohammed Naufal from RIO Trivandrum. Naufal, are you ready?
Am I audible, madam?
Yes, you are.
Good evening, everyone. My name is Dr. Mohammed Nofigedi, junior resident from RDO Trivandrum. So this is my case. Mr. Premraj, 38-year-old male who presented with complaints of floaters in both eyes for 6 months duration.
1 second,
Similar
Naushal.
complaint.
Could you put it on a slideshow? It's not on a slideshow. Yes, okay.
No, it's okay, madam.
It's fine. It's fine.
Hello, is it okay, madam?
Yes, it's fine. It's fine.
There was no history of any flashes or defective vision, no history of redness, pain in the eyes, no history of any rashes, no history of joint pain. He had history of painful oral ulcers which were recurrent, which heals after medication, but recurring for last 3 years, 2 to 3 times per month. No history of any genital ulcerations, no history of fever, cough, no history of any nocturnal diarrhea, no history of contact with pets, or no history of any headache, seizure, tinnitus, or tiger noted. No known comorbidities were there for him. He was not on any medication. He was second child of non-consanguineous marriage within irrelevant families, right? On general examination, patient had after ulceration, which were paler more generalized lymphadenopathy. Systemic examinations were within normal limit. Ocular examination, best corrected visual acuity was 6 is plano both eyes with near vision N6, normal color vision in both eyes, fields by within normal limit in both eyes. And examination, both eye cornea were clear. There were no keratic cells of flare in the anterior chamber. Anterior vitreous face also having no cells of flare. Pupil direct and consensual light reflexes were present with no RIPD noted. Intraocular pressure by Goldman ablation tonometry was 14 and 16 in right and left eye respectively. Fundus examination, right eye, media was having a few floaters with a disc seen normally with well-defined margins and healthy in neuroretinal rim. Vertical cup with cup disc ratio of 0.3 with vessels normal with AV ratio 2:3. Then in the periphery, the patient had whitish flat geographic lesions and a few linear lesions with irregular margins in the supratemporal quadrant, 9 to 1 o'clock in the mid periphery, as you can see in this picture. The surrounding retina was within normal limit. There was no evidence of vitritis, no evidence of vascular sheathing, hemorrhage, NV, collateral, serous vessel, vitreous hemorrhage, arteries or macular edema noted in the right eye. Left eye also, media was having a few floaters with a disc seen normally, well-defined margins and healthy neuroretinal rim with a vertical cup with a cup disc ratio of 0.3. Vessels, arteries were normal with an AV ratio of 2:3. Then in the left eye as well, we saw in the periphery, the patient had sheathing of the peripheral veins. Also, it was associated with a flat, whitish, irregular, linear lesions in the supratemporal quadrant. Surrounding retina was within normal limit. There was no evidence of vitritis or vascular sheathing. Vascular sheathing was there in this eye, left eye, for that mistake. Then there was no hemorrhage, no NV, no collaterals, no sclerosed vessel or vitreous hemorrhage, no hard exodus or macular edema noted in the left eye. Then we did an FA-ICJ in this patient in which the fundus autofluorescence showed hypofluorescent lesion in the supratemporal area suggestive of RP dysfunction in both eyes. Then towards the late venous phase of the fluorescein angiography, it showed disc leakage in both eyes with fan-like leakage in the peripheral veins. Also in the periphery as well, it shows supratemporal segmental leakage. ICG was relatively normal with a normal choroidal filling and no evidence of any granuloma noted. Then we did an ST-OCT right eye through one of the lesion, which showed an hyper-reflective disorganized inner retinal layers, which was suggestive of a healed retinitis. Also in the left eye as well, OCT through the lesion showed hyper-reflective inner retinal layers, which also suggestive of a healed retinitis. So we made a diagnosis of peripheral occlusive phlebitis in both eye with vaso-occlusive retinal changes. Considering the systemic oral ulceration and all, we made the possibility of Behcet disease first. Then on systemic evaluation, blood routine was relatively normal with normal ESR negative CRP. Then creatine phosphokinase was 306, which was high, and peripheral smears showed neutrophilic leukocytosis with and SSA post HLA no specific mutation detected, and in the CT chest, he had a few fibrotic strands in the apical and posterior segment of the right upper lobe. Sputum TrueNAT was negative. Interferon gamma T assay was positive. Pathology test was also positive. Then we did an upper GI endoscopy in association with the gastro department in view of recurrent oral ulceration, which showed grade A GRD with antral biopsy showing H. pylori associated chronic gastritis with focal incomplete industrial metaplasia. So after evaluation, we made a possibility of Behcet as well as a TB vasculitis since the CTCS was having an upper lobe fibrosis with the IGRA positivity. So we did a respiratory medicine consultation. They rolled out an active pulmonary TB and sarcoidosis. Rheumatology consultation also made a possibility of Behcet disease. Then we started the patient on tab-baseline 60 mg, which was tapered 10 mg per week. Then we started the patient on oral MMF 500 mg BD. Which was associated in consultation with the rheumatology department. Now we started the patient on TB preventive therapy in view of the suspicion of the TB on our request in consultation with the respiratory medicine. Now the patient is on follow-up. So my queries to the panel are whether tuberculosis should be considered as an etiological factor in this case, and are the retinal lesions are suggestive of Behcet's or just vasculitis on old vasculitis?
Pradeep sir, would you take the query?
Yeah, I was just hoping that we'll not discuss tuberculosis because we feel it's very, very contentious. And from our side, we feel that the level of evidence, despite whatever, we're not too convinced about the level of evidence that's there. And so from whatever you've presented, Mohammed, is one is IGRA has been banned. So if you go back in 2011, 2012, WHO for the very first time, they've never done it in the past, for the very first time, they actually came out with a declaration saying that IGRA tests or any of these tests in the developing countries should be banned for the diagnosis of tuberculosis, essentially because 1 in 2 are falsely positive. So you can look up that WHO director that's there. So they go so far as to say that it's not the disease, but the treatment itself which can cause serious harm to the patient. Okay. So, and they also say that, Mohammed, that the reason this is so, why they're advising this ban, most of these kits are made in the West, but they're marketed in the developing countries purely because there is no laboratory regulation in any of these countries. Okay, so please do not use this test. And we've done our own evaluation. So you will see that there is a discordance between the pathogy test and IGRA test. Sometimes IGRA is positive, pathogy is negative, and vice versa. So in that situation, sometimes people take whatever is of convenience to them. Pro-ATD people will say anyone is all right. So there is a lot of concerns about the recommendations on tuberculosis. So we certainly do not believe that etiologically tuberculosis, ocular tuberculosis per se is a cause etiologically. There are cases again where there are lesions of serpiginous choroidopathy that could have active systemic tuberculosis. So serpiginous choroidopathy again is multifactorial in etiology, and there are also reports where serpiginous choroidopathy is there, and then the patient is getting treated on steroids, and then somebody presents later on that TB was missed in this patient. Okay, what has happened in those patients essentially is that latent tuberculosis has got reactivated because the patient has been on a lot of steroids. It is not that the disease itself is causing the uveitic lesion per se. Okay, there are many other things. We have written this in letters to editor from our team from RP Center. So kindly look up the other details on our concerns with the CORD study, and all of these concerns have been there, but they're published essentially as letters to editors for multiple reasons. So, and again, as a youngster, I would like you to critically analyze yourself, evaluate yourself, and you'll get to know the level of evidence. Even now with all your AI, I don't know, but you can just look up what is the level of evidence that is generated, whether it is the highest level of evidence or there is lack of evidence. So just one final thing about this. So there was a Cochrane extrapulmonary tuberculosis committee that was there at AIMS, which was a event that was getting organized by the Department of Medicine. So for the eye, we from our center were there, and there were other teams from some other major institutes also, and they were trying to present the PCR evidence. The Cochrane team simply did not accept any PCR evidence because they're all in-house PCR. So in-house PCR means they're not reproducible, And so there are concerns about in-house PCR. So they, blankly refuse to take PCR as an evidence for disease etiology. Okay, so all of these points are there. Like I said, it's a contentious thing, and sometimes it causes a kind of a problem. So that's why I don't really get into it too much these days. I stay off limits for tuberculosis, but since you're specifically asking, I would not consider this as tubercular in etiology. Yeah.
So would you take the second query also? Are the retinal infiltrates suggestive of the infiltrates of Behçet's or a healed vasculitis?
And the oral ulcers, I think, are important that you mentioned. You said recurrent. So when
Yes.
you recurrent, does it pass the threshold of three per year?
Yeah.
Yes, sir, it was recurrent. Oral ulceration was recurrent.
Yeah. So, but B1 HLA B51 was negative. You said, right?
Yeah, B51 was negative.
It was negative, no?
Yes, sir.
B51 is negative, sir. Negative.
Is negative. So I think I would just treat it as an idiopathic vasculitis. And typically the Behçet's ulcers, you said what you mentioned were painful. Behçet's
Yes.
ulcers are typically not so painful. So what the cause for those ulcers, I'm not sure if it's very significant also, those ulcers. So I would just treat it as a idiopathic retinal vasculitis only in this. Yeah, but of course, if you develop other symptoms, and in uveitis, it is sometimes you like in patients with Harada's disease, they may develop hearing defect later on, poliosis later on, and you revise the diagnosis to a VKH subsequently. So sometimes you may have to shift your diagnosis if other features show up, and they may have to do some repeat tests. But I think currently with his age and the kind of lesion, I would go with idiopathic vasculitis. Yeah. And the other thing, again, as a youngster, the battery of tests that are being done, not recommended at all. I'm emphasizing this moment essentially because the tailored investigation, most of the uveitis remains idiopathic. Okay, it's only that 5%, maybe 8% where you need to pick up etiology. The remaining actually there. So searching for it when no systemic features are there, it's like searching for a needle in a haystack. So you're going to do a lot of investigations, and so I would really discourage that kind of an approach. And many times you also see that it is something comes positive, and then you say that okay, because of this is the etiology, this is not the correct way. Yeah.
So, would you advise a repeat FFA to decide regarding the continuation of immunosuppressive therapy?
I'm not sure if I've given immunosuppression also in this situation. So again, there is absolutely no studies that have been done, even if steroids in patients with retinal vasculitis, even if steroids, the risk with vasculitis is the proliferative disease that subsequently happens. Okay, and most of these patients with idiopathic do not even have macular edema. It's infrequently see macular edema, and whether giving steroids prevents them from going into a proliferative stage, that there is absolutely no study at all. So I would not like Behçet's. If you confirm it as Behçet's, then yes, you have to give them immunosuppression. But in the absence of that confirmation, I would not. Yeah.
So, would you say that HLA-B51 is conclusive for Behçet's along with the systemic criteria?
Wouldn't say this is supportive evidence only. Yeah, you have those major criteria, minor criteria, and
Yes.
that if you have, I think this is just a supportive kind of a thing. So if you're not finding that fulfilling that major and minor criteria, I think we should withhold that diagnosis.
Okay, sir. Anuradha, madam, would you like to add something? Madam, you are not unmuted. Could you unmute?
Sorry. Can we go back to the fundus picture and the autofluorescence?
Dr. Naufal, could you share?
So it was there in both eyes, and it was kind of symmetrical, right?
Yes, ma'am.
I'm a little bit concerned with that because I'm just wondering whether there's underlying dystrophy here. Because you wouldn't expect that kind of hyper autofluorescence. And if you look at the macula, you have what looks like almost like a bullseye maculopathy in both eyes. Can you go to the autofluorescence?
Yes, madam.
Yeah. Do you see that?
Yes, madam.
I wouldn't really expect this in Behçet's. You can have vascular leakage in retinal dystrophies. I would suggest that you consider that possibility as well.
Madam,
Okay,
the
madam.
disc will be hot, like in FFA, I think it was hyperfluorescent, wasn't it?
You can have vitreous cells, you can have disc involvement as well.
Oh, okay.
This symmetry is very worrying.
Okay, yeah. Because during the course of 2 years, the same picture is being maintained, and the OCT finding through that lesion was like a full thickness lesion, retinal lesion. So that's why we were a little. Could you show that OCT now?
So it didn't respond to the immunosuppression or the steroids.
Actually, it is status quo. So we are in a confusion whether we should repeat the FFA or not. But the patient still has complaints of floaters. We don't know if it's related to this disease or not.
No, I would work up, I would rule out dystrophy as well.
Okay, madam. Thank you for that input.
No, I missed that fundus autofluorescence. But this is through the foveal, is it? The fovea, your OCT, is it passing through the
No,
fovea?
sir. It's actually through
No,
the
sir,
lesion.
it is through the lesions.
You don't have it through the fovea. Okay.
We do have, sir, but it was normal actually, but I didn't include in this PPT.
Yeah, no, I do agree with what the brother is saying. So there could be a concurrent pathology there. Yeah.
Will a family screening help?
Yeah, should be. I think should be done. Yes.
You also need to do electrophysiological tests. Yeah.
Okay, ma'am.
Thank you, ma'am. We had an extensive discussion, and thank you so much for all the panelists, to Pradeep sir. May I call upon Dr. Vijayalakshmi to give the vote of thanks. Thank you to the participants who have patiently stuck up with us, and we definitely benefited from the session. Vijayalakshmi madam is there?
Madam, you're muted, madam.
Yeah, I know it's very late. Anyway, on behalf of KSOS and our scientific committee and all the members present here, let me extend a great thank you to Pradeep sir for his wonderful talk, really enlightening talk, crisply and precisely teaching all the PGs and practicing ophthalmologists here. So thank you once again for joining our expert series talk, and you have been the first. And a big thank you already mentioned for the accepting our invitation also. And thank you, Anuradha ma'am, Dr. Jisha and Dr. Sandhya for their valuable inputs and the great discussion we had. And our PGs also, Dr. Mohammed Naufal, Arshi and Ashwati for their nice case presentation. And of course, our delegates who have been here for the webinar throughout. Of course, a little bit of dropouts are there even then. We have got some numbers there. And our own member, Mini, for the wonderful leading discussion, lively discussion, and for the wonderful job. Thank you all once again. See you all for the next series. Good night.
Thank you, ma'am. I would like
Night.
to extend our heartfelt condolences to Dr. Anuradha ma'am. She came in spite of losing her father last week. We are so thankful to you, madam, and we join in your sorrow. Thank you so much. So we shall end the series. We have.
Yes, Dr. Mini. Thank you all for joining. Thank you, Pradeep sir and Radha madam, and all the other panelists.
Thanks everyone then. Good night.
Good night.